Hey, hey everyone. It's Naomi Wolf. I'm so happy to be here. You'll have to forgive me because I just had a root canal, but nothing stops our effort to inform you and illuminate the positives in the crisis that we're surrounded by right now. And I'm with DailyClout, and I'm really, really honored to be welcoming Sarah Robinson. Sarah, welcome.
Thank you.
We're so happy to have you. So Sarah is Ms. Robinson, but I'm going to call her Sarah at her request, is a chiropodist, and she owns and operates a private practice in Wasaga Beach, Ontario. So Sarah is one of our profiles in Courage because health providers ranging from doctors and ER nurses to chiropodists now, and even a former health minister of Canada are stepping forward to talk about their views of lockdown and some of the challenges that they see or some things that they think should be done differently. So Sarah, why don't you tell me where do you practice and what led you to make the comments you did that led me to want to talk to you?
I work in Wasaga Beach, and I work with a very high-risk patient load. At the beginning of this COVID journey back in March last year, our profession was limited to emergency care, and we were not allowed to bring patients into our offices. And at one point, we were even told if there's something we can't handle through telemedicine, to send them to their doctor's office, a walk-in clinic, or a hospital. Mm-hmm. But in my risk assessment for my patients, they are so high risk for COVID if they catch it. If I have to send them for a basic foot care procedure into these spaces where COVID patients are, I'm going to put them at higher risk than I would be placing them if they're coming into my office for foot care. And then I've also, in my years of clinical experience, doctors in the emergency department do not have the tools at their disposal to take care of foot conditions in the same way that I do. So we were allowed to be open for emergency care, and we stayed open through the whole COVID. I've never shut down completely except for the time where we had vacation booked. But I took the steps to evaluate all the Ministry of Health guidelines and make my office as safe as possible for my patients. And we participate in the triple screening, and they're checked when they come into the office for their temperature and re-screened again to make sure they're not feeling unwell on the same day. And as to my knowledge, we have not had one patient a confirmed positive. We don't have the cases in our community. So the risk for my patients, if I'm not taking care of them, is much higher.
Wow.
Their risk from COVID right now.
So let me jump in and make sure I understand. It sounds like a really terrible policy. I mean, one of a number of terrible policies we're hearing about around the world in developed, sophisticated democracies like Canada, like the UK, like the United States. You're saying, and I believe I've seen this on the public health guidelines for health providers that you shared with me, the link for everybody in your profession. It's really thorough, but it definitely says you're not supposed to be seeing your patients yourself. And so what you're saying is people who have foot conditions, which usually are not terrible emergencies, right? They're chronic, right? I mean, they want to see you because they're in pain, they're uncomfortable. Instead of being able to see Sarah, who knows who they are, knows what they need, knows their context, knows if they're neglected, knows if their nutrition's good or bad, knows if they're isolated, they're not allowed to see you except the way I'm seeing you, right? If I were to show you my foot, you can't do that much with it, right? Over telemedicine. And you're sending them to somewhere where people are not chiropodists, they're not trained like you are in this specialty, and they're at much higher risk of catching coronavirus. Is that a fair assessment of what you said?
I shook my head. I couldn't sleep at night. The week before COVID hit, I had a lot of patients who were overdue for their appointment, and they came in with gaping holes in their feet, ingrown toenails. So it was just the timing of it. I was already supercharged with how high risk my patients are. My patient load is heavy. It's very difficult. If you miss your appointment by 2 weeks, you have an ingrown toenail in my practice, or you have a wound, or you've got blood bleeding out into your skin because of the pressure from the callus.
Mm-hmm.
So if I can't see you on your regular schedule is urgent care. And why should I have to wait until a high-risk diabetic person has a hole in their skin before I can bring them into my practice? Now we're risking cellulitis, infection, possibly leading to an amputation.
Oh my God. So you're really echoing and adding detail to what Dr. Patrick Phillip, whom we also interviewed, said, which is telemedicine does not replace hands-on care, and that people, COVID policies, which are moving heaven and earth to kind of centralize care, to do everything to avoid COVID, right? That's why you're not allowed to see patients one-to-one, or at least you haven't been in your office. That's actually leading to bad medical outcomes. And some of them, again, I'm restating, that I've heard are, and they're serious for older people, diabetes, amputations, bleeding from the feet, pain and ingrown toenail, conditions that really do need management. So these people are suffering and at risk as a result of not being able to see you. Is that correct?
That's right. So after about a month of being restricted to emergency care, we were allowed to do urgent care. And in my office, because my patients, they just can't miss their appointments, we were able to open the door to a lot of people. We didn't have so much elective care, like my folks who just come in because I do a better job than they do, and they have minor conditions and can manage on their own. They didn't come in during that point. So we were able to open the doors for urgent care. And unfortunately, a lot of patients would wait until they had an ingrown toenail again. And during the first 3 weeks when we were restricted to emergencies, one of my colleagues in Toronto, his patient, non-diabetic, so not predictable even. You wouldn't even think that this could happen. He had a corn, the corn ulcerated. He got cellulitis. He landed in the hospital for 3 weeks. And then he was on IV antibiotics and needed over a month of home care in the community. So now, because he missed one podiatry appointment with his podiatrist in Toronto, all of this happened that could have been avoided if we hadn't had that emergency care restriction.
I understand.
Triage on the phone.
Say that again, Sarah?
Patients don't triage well on the phone.
What does that mean to a layperson?
So when you call me, you don't know what's going on with your feet.
Right.
Some of my patients can't see their feet. They can't reach their feet. They can't feel their feet. So they don't know what's going on down there. I had a patient, he thought he had warts. It was an initial assessment, and my staff member, Nadine, she's amazing. She asks more questions. She doesn't take their word for it that it's a wart. And so she realized through her interview on the phone that this person needs to come in. She thought they had open sores. And they did. They had open sores all over their feet.
Breaking. So you're saying because of COVID, people who have conditions aren't getting treated properly because telemedicine simply cannot communicate. And you're giving specific examples of people who can't see their feet for many reasons. People who are in wheelchairs, people who are obese, I imagine, who people who can't feel their feet because of neurological conditions, neuropathy. I'm guessing it's not that simple if you're a podiatrist or a chiropodist to do telemedicine. Again, I don't even know, it doesn't even make sense, to even physically, hold up my foot to you, right? How do people even do that? And I'm mobile.
I had colleagues who attempted to do telemedicine for ingrown toenails. So you take the toenail clipper and you're going to trim it like this. And they watched on video while their patient lacerated their toe.
Oh, God.
Yeah.
It's terrible. So basically, it's like distance learning, but for medicine with, horrible outcomes by being driven onto a technological platform that is not designed for medical care of this kind. And one of the things, can I just ask, one of the things Dr. Phillip said is that a lot of conditions start out small but get much worse, and you need to put hands on the patient. As a chiropodist, do you also feel that there are things that you pick up one-to-one that they can't communicate to you or you can't tell by telemedicine?
Absolutely. they don't always have the language to explain what's going on down there. We talk in our technical jargon and we have to bring it down to layman's terms. They don't even have the layman's terms to tell you what's going on. So when we do chiropodists and podiatrists, we do a lot of stuff with our hands and our eyes. I have to do a risk assessment on each one of my patients who comes in. So especially if they have diabetes, but even if it's not known that they have diabetes, they could have other neurological problems. So I have to check your pulses. What is your blood flow? I can't just send you to the vascular specialist and get an objective measure of that. So I look at how quick your refill is. I pinch your toe. I watch it re-pink. I feel your pulses. Check the tissue quality. You can't tell tissue quality on a camera. It doesn't come through. Unless it's really bad, I'm not going to be able to tell. I can't tell a temperature gradient. I can't tell a temperature difference side to side. So we do that. We do a neurological examination. Can you feel sharp? Can you feel blunt? Can you tell the difference? Can you feel the monofilament? Can you feel vibration? Deep pain? I can't do that over video.
No,
and
absolutely.
so then we also look for structural deformities. We have to check your shoe fit, watch you walk, and gather all the information about whether you are at risk of an ulcer, figure out why the callus is coming. Most of my care is hands-on care. I'm not giving people a pill. I'm cutting callus off. I'm trimming bad toenails. I'm debriding an ulcer. Or I'm physically feeling like sometimes it's a joint alignment problem. We've got things that happen in your feet. Bunions don't start overnight, but why is this happening? What kind of forces are leading to this foot going wonky? So if I can't see you in person, I can't do anything. And then we had some really arbitrary limitations on who we could do certain things for. So one of my colleagues had a patient who was declining very quickly with her foot mechanics. So when certain ligaments start to stretch and go, you need to do something ASAP or that foot's just going to go bad. So she provided orthotics for this person, and then the insurance company wanted to know why this was essential. This is not a hospital worker. This person's not an essential worker.
Is it coronavirus that the coronavirus is determining who gets care and who doesn't get care based on whether they're an essential worker?
We had limitations on who we could do certain things for. I had a wart patient who was limping. So he's limping to the point where he's developing tendinitis because he's guarding from this wart. We were in urgent care. That sounds urgent to me. So got him in, we treated the wart, and then the insurance company wanted to know if it was done by telemedicine. And
so you're being discouraged from giving proper care to your patients in the name of addressing the pandemic. So when telemedicine started in Canada with you, is it supposed to be protecting you from being infected by your patients or your patients from infecting each other? And why do you feel comfortable that it's actually okay for your patients to come see you in your offices?
I think a lot of it is fear-based. I'm not bringing symptomatic patients into my office, and we're triple screening them. We have the plexiglass at the desk. And I also, because I have a very vulnerable patient population, they are making responsible choices about where they go, and they're making accurate assessments about how they feel because they don't want to bring it to me.
Right, and so it's less risky. You would say it's less risky for them to go to you and get properly taken care of than to go to be neglected and have things get worse and then to go to a high-risk setting. Well, let me ask you this.
I feel comfortable with them in the office because making good decisions. I don't feel like I need to protect myself with telemedicine because my patients and I are protecting each other.
And it sounds like you're communicating with each other too, so that you can keep each other safe and healthy. And by the way, I just want to note, I've been reading a lot of peer-reviewed literature about things like asymptomatic transmission and aerosol transmission. The evidence is very weak for asymptomatic transmission. So the kind of screening you do, from what I read in that link for health providers, taking the temperature, doing the questionnaire, doing the visual assessment, the things that you you already do. I think that's what you mean by triple screening.
Yeah.
That is very unlikely to get you sick or to get people sick from each other, since you're screening that way. Is that correct?
Yes.
Okay, so that's very important. Now let me go to, and let's talk about aerosols for just a minute. I know you're not an expert, but you did talk about Hepa filters and how you feel like it's very safe for people to go get the kind of primary care that you've been forced to give on telemedicine, because you have a basic understanding of infectious diseases in the air. And again, I've been reading peer-reviewed research showing that when you open a window or when you have good filtration, the viral load drops in a room. Do you want to speak about why you feel comfortable with the air quality of where you practice?
So we've already had air quality concerns just from the practice of chiropody, podiatry. We trim a lot of toenails, we file toenails, thin down toenails, and there's a lot of toenail dust and skin dust in the air. So before COVID hit, about 8 months before COVID hit, I already had jade filters in each treatment room, and they have a UV lamp, carbon element, and a HEPA filter. So I'm able to exchange the air through that filter between patients, as well as managing the podiatry chiropody specific air quality issues. So because I have that in the treatment area where I'm spending the most time with my patients one-on-one and in close contact between my medical grade mask and their either medical grade or fabric mask, we're not going to have a lot of exchange of air between us, and they're not coming in coughing, they're not coming in with symptoms. So I have very, very low, I feel like I'm very low risk in my office. I feel like I'm lower risk in my office than I am in a grocery store. Mm-hmm. And we have been open. So I never shut down. I never did solely telemedicine. My patients who needed hands-on care were in my office. And once
the rules, you saw them against the rules?
No, it wasn't against the rules.
Okay.
So we were allowed to provide care, and if you were putting measures in place in your office that met the public health standards. So when we were told to limit ourselves to emergency care, we went through the schedule, and anybody who had ingrown toenails, wounds that we were managing, anybody who was at risk for ulcerating was kept at their regular schedule. Everybody else was delayed. And then when we were able to do urgent care, I have not done telemedicine. My patients cannot telemedicine. They don't have video. They don't know how to use the iPad. They don't have computers. I don't have the demographic for it.
And so I'm sure a lot of doctors and healthcare providers are in a similar position to be forced to see people through telemedicine who may not even be, used to computers or have internet access or be able to articulate what's happening with them. It sounds like a potentially catastrophic situation. So, and the last thing I want to say before we pivot is you mentioned UV filters, and President Trump was made fun of, and I didn't vote for him, but he was mocked for saying UV light can help with the virus, but a Tel Aviv University peer-reviewed paper has found that in fact UV light can help with sterilization and with making air cleaner of viruses and infectious material. Is that not correct?
It is correct, and there have been UV sterilizer units available, mainly used by the dental field, for many years before COVID even happened. They generate aerosols in your mouth all the time, and there's, it floats around their offices. They have even more things to deal with than I have to treat people in person.
So basically, it sounds like there are many time-tested, peer-reviewed things to do to make a safe environment to treat people, and presumably extrapolating, though that's not your job, to maybe gather students together safely or gather people in a town hall safely. I mean, it's not up to you to make that decision, but it sounds like there are many things we can do short of locking everyone at home inside, getting sicker and sicker. Some people are dying of heart attacks. Some people are dying of, deferred care like you're describing, or getting more badly injured. And it sounds like with serious outcomes, like losing the use of a foot or a limb, if things go on long enough. So let me now ask you about the emotional state of your patients in lockdown. you said that you're in an area with a lot of older people. And as a chiropodist, you see a lot of older people. These are the people, as you said, are most high risk for coronavirus. Do you think as a healer that isolation is good for them?
Absolutely not. Some of my patients are doing really well. They don't know how they would have gotten through this without their Zoom. They're having Zoom parties with their family, Zoom meetings. Some of my patients are lower risk. So when we were allowed to have our social bubble, they made the risk assessments themselves that it was safe for them to be around their grandchildren because they weren't in school, and their children are working from home, so they brought their children into their bubble. So they're doing a lot better. But especially right now where we're under travel bans and you can't allow anybody else into your household, some of them are really...
In Canada? Excuse me. You can't let anyone else into your household in Canada?
In Ontario, if you let someone who's not a member of your household into your household, you could be subject to fines.
Wow.
Yeah. So we had a case in Simcoe County where a woman made the choice to drop her children off at her parents' house so that these young children wouldn't be touching groceries in the grocery stores she shopped, and they got fines.
Good Lord. So what is this isolation doing to your older patients, the ones who don't have Zoom or who have language barriers, who don't have people near them?
They don't know what to do with themselves. They're isolated. Some of them aren't walking as much. They're not making the effort to go out as much. Their health is declining. It's worse for my patients who are in retirement residences. Some of them aren't allowed to even come to my office. If they come to my office, they'll be locked in their rooms for 14 days.
What?
So, yes.
That's so punitive.
It's become a crime to catch COVID, and we're not making good risk assessments as to what safe spaces are to allow people out. I have one patient who has a wound that we're treating. If he needed new shoes, his shoes were contributing to the wound. I had to order them into my office and have him try them on, and if they didn't fit him, I would exchange them, because if he goes to a shoe store, he would have to be in his room for 14 days. And our patient I had a patient who went to a cardiologist appointment and had to be in a room for 14 days. So when you're only able to walk around your room, you're going to become deconditioned. Your legs are getting weaker. And when you're not using the muscles in your legs, your body has no reason to maintain your blood flow, and the blood flow declines.
Oh, God. This is terrible. And what about emotionally? I mean, don't older people need social stimulation in order to stay alert and to take care of themselves? And what does it do to them to be not able to see their families or see their grandchildren?
Some of them, just because they're not talking as much, they're feeling like they're not finding the words as quickly. They're feeling like they're losing their sharpness. Mm-hmm. Some of them are quite lonely. It takes quite a toll on people, and a lot of people who come to my office, it's the only place they're going. Their kids are dropping off their groceries on the porch, so they're not even going out into the grocery stores. So they are a lot needier emotionally. So, and some are just so grateful to talk to somebody other than their spouse. And then the ones who live alone, they're either talking on the phone with people. It's their first time talking in face to face for weeks.
This is heartbreaking. I mean, I know you're not an epidemiologist, but I keep, from everything I'm reading, this is not even good science.
It is.
Right? Isolating people. I mean, the peer-reviewed studies are in that lockdown areas don't do better than not locked down areas, and that other factors like good nutrition and sanitizing and windows and doors open and sunlight and vitamin D and all of these things that boost immunities are better. And I keep thinking about old people and immunity, right? Like, there's so many peer-reviewed studies that show that older people's immunities decline when they're isolated and depressed. Is that not your experience?
I haven't seen objective studies of it, but when you are stressed, when your stress hormones increase, which they will if you're lonely, your immune system doesn't work as effectively.
So let's go now. You've been so generous and you're such a good care provider. I know your patients are lucky to have you, Sarah. You're really making me cry. Again, like Dr. Phillips made me cry. You're making me cry. It's such a catastrophic situation. If you were premier with your background in healthcare, what would you change about COVID policy in Canada and lockdown policy?
I would target the biggest problems. So they talk about the Pareto principle. If you put 80% of your resources towards 20% of your problems, and that small amount of problems, like the 20% is just because of the way the scale goes. Have you seen the Pareto scale? So if you focus your attention on the biggest issues, which are nursing homes, retirement residences, and factories. Mm-hmm. If you put all your resources into those and plugged up those holes, mm-hmm. we would be having better improvement overall in the numbers.
And letting people presumably walk outside, socialize, shop carefully, right? See their families. I mean, would you allow people to, we're in a free society theoretically, but do people need to have contact with each other to be healthy?
I think people need contact with each other, and I think people need more information to make an informed choice about what they should be doing. So yes, there are some people who are vulnerable, who are younger. They need to protect themselves. My patients protect themselves. For a good amount of time, they were allowed to be out. They were allowed to be doing things, and some of them went for haircuts. Some of them went to the grocery store. Some of them went to restaurants. And they chose those things based on their own health factors and their own healability, their own health status. And
right. When people,
first advanced COPD patients to stay at home, they made that choice for themselves during that time. So we can't, when I treat my diabetic patients, I don't tell everybody the same thing.
Right.
I look at your risk factors. If you have good blood flow, if you can feel your feet, if you don't have any structural abnormalities, mm-hmm. and your tissue is healthy looking, you're at very low risk for a diabetes pressure ulcer. So we talk about how to maintain your health and wellness. Mm-hmm. And if you have risk factors, I don't tell you, if you don't come into me every 6 weeks, you're going to get your leg cut off. I say, here's the risk factor. You can't feel your feet. Mm-hmm. Here's what we're going to do about it. You have to check your feet every day.
So moving to the COVID example, it sounds like you're saying if you give people good information and treat them like adults, and people are the best experts with their doctors on what is safe for them to do, what choices they should be making, and that protects everyone. Is that a fair way to summarize what you're saying?
And because we've been using scare tactics, people are shutting down and tuning out. Right. We were told there were going to be bodies everywhere. It's like the Spanish flu. We're going to have mass graves. We're not seeing that kind of a death toll. And so people are saying, well, what's the deal here? This isn't a big deal. So some people are just tuning out and going about their business. And instead of actually, recognizing I've got a sore throat, I've got a bit of a cold, we can't know if that's COVID until we know that it's COVID or not. You have to get a test to see if that's the virus. And the other thing is that you can't go around spreading your cold, because if you spread your cold to other people, if I catch a cold from a patient, I have to shut my office down for 2 weeks, get a COVID test, clear my symptoms before I can open up again. Mm-hmm. So we have to be making good decisions about what we're doing. And if we're only fear-mongering and people are tuning out, mm-hmm. they're not going to make good decisions.
Understood.
And then the other thing about my patients is the patients who can afford to see me at this stage in their life are wealthier on average. They're higher educated than the patients that I don't see. So it's all about the social determinants of health. We used to talk about this a lot in the 2000s, mm-hmm. and it fell out of favor because basically if you're poor, you're going to be sicker, and nobody wanted to throw money at it or address that problem in a real functional way. So it just kind of fell by the wayside. We can't kid ourselves and think that a person who has a mild sore throat and works in an Amazon distribution factory and has no paid sick leave and is that one single paycheck away from losing their apartment and not feeding their children is not put up against the wall to just, well, it's only a sore throat, I'm just going to go to work because I have to carry on. We have supports in place so that people, we're not all in the same boat.
Right.
And those people who are in that boat need the support so that they can get immediate access to EI, so they're not putting the whole factory at risk of an outbreak.
Understood. Which is paradoxically the way quarantines used to work before this unprecedented experiment. We used to just quarantine the sick, until they were healthy. Now we're locking everyone down, which is completely unprecedented. What do you think? 2 last questions, I promise. The Great Barrington Declaration. Again, I know you're not an epidemiologist, but what do you think? I've been looking at the death tables and the hospitalization tables, and there's so many kids suffering from being locked inside and teenagers suffering, mental health issues, suicidality, child abuse, and so on. The data really do show that, as you said, it's people in their 70s who are the mean age for hospitalization, people in 80 which is the mean age for death from coronavirus. And there had been 1 death in the death tables I'd seen since the pandemic began, and it's very sad, but it's one death out of a whole country of anyone 0 to 19 from coronavirus. So what do you say about the Great Barrington Declaration's idea that, younger people should be left to go around about their lives, go to school, start their careers, go to work, and older people, who are vulnerable and people with health, really compromised health need to be supported, as you just said, in sheltering if they want to. Is that a good public health policy?
I think we need a bit more conservative an approach than that, because you bring in, I'm in a lower risk demographic, but I treat higher risk individuals. So I have conducted myself accordingly to make sure I don't get sick and bring it back to my patients. So because we have so much interaction between the public and these people who are at highest risk, we still need to have some safety measures. We can't just all bump around freely to get to herd immunity. But I think we're kidding ourselves if we think that we can lock it down and eradicate this virus. We're in a triage situation where we need to put the resources towards where they can best serve the public and reduce the cost of COVID. And unfortunately, some people will say to me, but that means that some young people who are high risk are going to die. We're not all going to get out of this. And might be one of the ones who dies from COVID. Every time I have a cold, since I had pneumonia 5 years ago, I have a real rough time of it. So some of us aren't going to make it through this. And the first week of this, where we didn't know what was going on, I sincerely thought I had a chance of dying. Now I'm not quite as, because we have time to think and you assess. So it's not quite as bad, but we're not all getting out of this, and we're in triage now.
Right, I understand. So basically you're saying a modified version, I think, of how can I put it? It sounds like you're saying what a lot of epidemiologists are saying, which is lockdown is kind of an illusion. You can't get rid of a virus by keeping everyone inside. And what you're saying is very mature, it seems to me, which is some people are going to die in a pandemic, and that you should devote your resources. It's really smart policy, Sarah, to high-risk environments and high-risk populations, and accept that there's going to be some risk. Do you want to say one final thing about accepting risk? Because, I definitely feel in a free society, we accept risk when we get into a car, we accept risk when we get on a plane, when we hire a baby, we do due diligence, but there's always risk in the world. And this is the first time there's been massive global policy in free societies in which the presumption is we can manage ourselves to a place where there is no risk. And I just want your thoughts about that as a healthcare provider.
Anytime anybody comes into my office, I can't guarantee, I'm working with sharp instruments, I can't guarantee you're not going to get a bleeding point. I can't guarantee absolute 100% safety. My patients accept when they come into my office that I have done everything I can to mitigate their risk of getting COVID. We've done every measure possible to reduce the risk of transmission. And if we insist upon having 100% zero risk, anytime anybody leaves the home, anytime anybody does non-essential shopping, we're going to have nothing left to come back to as a society once this is over.
Well put. Beautiful cautionary words to end on. Sarah Robinson, another Profile in Courage. We respect you so much. Thank you so much for speaking up really for your patients and being a voice for a lot of people who, aren't able to be with us on this call. I hope many, many people hear what you have to say. Thank you for being so generous with your time. Stay safe. Take care. Sarah Robinson. Okay. And if people want to reach out to you, where do they find you?
I am on Twitter.
And your clinic, if they want to call your clinic and book an appointment.
We're the Foot Clinic in Wasaga Beach. The phone number is 705-627-5524.
Thank you so much, Sarah Robinson. Take care. Be well. Thank you.